So we'll start with the corneal scraping. As we all know, this is one of the important means to do the diagnostic as well as the therapeutic measure also. Because in this case, if we scrape the superficial part, probably the penetration of drug would be easier. So when do I definitely scrape my ulcer? I always scrape when it is moderate to severe ulcer, not responding to the empirical treatment, showing atypical presentation post corneal surgery, corneal ulcer, when there is a history of trauma and there is a suspicion of ocular surface foreign body, and when I have one-eyed patient. I prefer to use proparacarin eye drop because it is least bactericidal. I do not personally prefer wire speculum. My preference is 15 number surgical blade without handle. What I use, I open the blade and use the same, the pack in the folded manner to use it like a handle itself. That gives me good control. Then glass slides, cover slip, and culture plate. And if there is a possibility, always keep something for managing corneal perforation like glue. So we should do the scraping always in one direction, and we should scrape the base as well as the edge of ulcer. Like here we can see scraping the edge, and here we can see as there is a very minimal material at the base, probably we need to take some bold strokes also. And whenever I'm doing the plating, I'm doing it over the slide, I always write the MRD number. I always make a black mark at the base of slide, one for the gram, another for the KOH. Similarly, for this plating also, we should always make it superficial in the C-shaped stroke, because if we put it deep in the media, then the growth of aerobic organisms will be hampered. I get the sebaroids culture plate, but if we are getting it in a test tube, then always put the blade in the culture media deep. Do not touch the wall of test tubes. So that is how it should be. And here we had one case with corneal surface foreign body along with infiltration. We did the initial scraping. It responded well to the treatment. After a while, it got stuck at this point. Nearly 15 days, we didn't see any response. Then we scraped it again. It started responding, and ultimately it healed well. So my take-home message would be, meticulous scraping is the key to successful treatment of corneal ulcer. It should be unidirectional. Both the base and the edges of ulcer should be scraped, and repeated scraping may be required in different cases. Thank you.
Thank you, Dr. Mamta, and some very good, interesting tips that came out from this. That we have to scrape the edge and the base of ulcer. Most importantly, we should remove the sloughed material first, because many times there is a false negative, because sometimes we give it to our residents and they don't remove the slough tissue. So that is very important. It helps both therapeutic as well as diagnostic because also you remove the infective load as well. And direct plating is something which we should prefer.
I prefer
that gives better yield than carrying in a transport medium. Any comment